Hello and welcome everyone to tonight's webinar on prostate cancer screening, diagnosis and care. This webinar is brought to you by Capital Health Network and the ACT Prostate Cancer Support Group, which is affiliated with the Prostate Cancer Foundation of Australia. Tonight's speakers represent a comprehensive panel of medical specialists and people with lived experience. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region. I pay my respects to their elders, past, present, and emerging. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. Their land was and never has been ceded. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Associate Professor Hodo Haxhimolla, who is a urologist, Dr. Patrick Bowden, who is a radiation oncologist, Dr. Neha Aggarwal, who is a medical oncologist, and Mr. Greg McRoberts, who is the president of the ACT Prostate Cancer Support Group, and he will speak on lived experience of prostate cancer. So housekeeping, all participants have been muted. Please type any questions you have into the Q&A section and not the chat box on your Zoom panel. We'll have a question and answer panel session after all the speakers have presented. The presentation itself will be uploaded to the Capital Health Network YouTube page, and you're welcome to share it with your networks. Regarding CPD, please fill in the post-event evaluation survey. CHN will email you a certificate of attendance after the event. Please feel free to self-report 1.5 hours of educational activities to your CPD home. And before we start, just to highlight Health Pathways again, which is a free and accessible resource for primary healthcare practitioners, and it has a lot of resources on prostate cancer. The login is together, all lowercase, the word together, and the password is for health, one word, FORHEALTH. Okay, so now the exciting bit of the night. Our first presenter tonight is Associate Professor Hodo Haxhimolla. Hodo is an experienced urological surgeon that has been practicing for 13 years at the National Capital Private Hospital. He completed his Bachelor of Medicine and Bachelor of Surgery in 1992 at the University of New South Wales. And he completed his urological fellowship and training in 2002 and obtained his specialist qualification Fellow of the Royal Australian College of Surgery, Urology in 2003. Hodo is an experienced and certified Da Vinci robotic and laparoscopic keyhole surgeon at the National Capital Private Hospital. So over to you, Hodo. Thank you very much.
Thank you very much, Leonie. Thanks for inviting us to talk on cancer of the prostate and updates on the topic. I want to start with a case presentation on a 48-year-old gentleman presents with lower urinary tract symptoms, presents with hematospermia, no history of any hematuria, PSA of 2.6, with a ratio of 5%, with a digital rectal examination being normal, and an ultrasound of the prostate only 30 cc's, nothing outstanding. However, when we looked at the MRI, in this kind of a patient, we see that in this particular case, we can see that there is a bit of, on a T1 image there, we can see this bright area in the seminal vesicle, which in this case obviously was a inflammation of the seminal vesicle and prostatitis, which is the most common cause of hematospermia in a young person. However, on a different group of patient, we can see here similar presentation, and the patient has got a Pirates 4 lesion in the area in the diffusion zone here, as you can see, which is very bright. So this particular patient on the diffusion with the abnormality that you see on the MRI on a biopsy shows an intraductal carcinoma with a 3+4=7 disease. So you can see that sometimes simple hematospermia, when investigated in a certain age group with the MRI, can lead to the diagnosis of cancer. So hematospermia, most common cause, as we mentioned, is inflammation in the prostate, prostatitis, and sometimes bleeding into the seminal vesicle. But in a specific age group also, it can mean intraductal carcinoma in situ, and intraductal cancer, which can be more aggressive form of cancer and needs to be treated accordingly. So as we know, most of the time in the past, we've looked at PSA, DRE, and family history as our main things that we did trying to do the diagnosis of prostate. But for the last decade, and we certainly have been one of the leaders in terms of the MRI in the country, we've been utilizing the MRIs and this has led to earlier diagnosis of cancer of prostate. Obviously, the PSA, it's a simple blood test that we do. If you look at the PSA ranges, if the PSA is less than 4, that's meant to be considered as within the normal cutoff, depending on the age group. It's still the cancer of prostate can be up to about 25%. And if it's 4 to 10, 25 to 30%, and if it's more than 10, more than 50% cancer of prostate. This is obviously a debate that has been going on for a long time, whether we screen or not screen. But as we know, this is a jury in terms of is out, because most of the patients these days are self-selecting to be tested for the cancer of prostate. So screening in itself is not the right word to use, but testing of the PSA is certainly what has been happening for the last number of decades. And you can see here that if you look at American studies that show that since the PSA has been introduced, the number of deaths in the United States from cancer of prostate mortality has reduced significantly by up to 50% in the population that has been tested for cancer of prostate. And this is very similar if you look at in our country, in Australia, where there's been a reflection of about 30% reduction in mortality in the screened population. So if you look at, we can see also in this slide here that over the same period of time, there's been a significant reduction in terms of decline of metastatic cancer of prostate that we see since the PSA screening period. The question is, how do we avoid possibility of having patients presenting in this stage, when you can see that on the bone scan, you can see widespread metastatic disease, and on this side here on the MRI, quite an extensive tumor, which is T4 disease really on the MRI. Digital rectal examination, it still has its place, and I think it's important to do this. Certainly sort of as urologist, we would do this in the office. And sometimes it does help us in terms of trying to determine, especially in the patients that have got a lower PSA, to see whether we can feel any palpable nodule in these patients. And also in terms of the diagnosis, if the PSA is very high, we want to also know whether the overlying mucosa that is over the nodule, for example, whether we can move that mucosa and whether this patient is still suitable for a radical prostatectomy when the PSA PET scan is negative. So digital rectal examination, obviously we are looking at the peripheral part of the prostate, and that's where 75% of the cancers will take place. Obviously, we will miss anything that's coming on the anterior part of the prostate. So in the prostate lesions that we can see here, obviously cancer can take place in the peripheral zone, in the central zone, and transitional zone, including anterior fibromuscular stroma. And these are the zonal representations of the prostate that you can see. And this is on a specimen, which is a histologically mounted specimen. This is the peripheral zone of the prostate here, with the transitional zone here in the center. So obviously, this is the Gleason scoring system that we are showing on this slide. And you can go from the lower grade to the highest grade here. And now we're using the isograding scoring system. And you can see here, Gleason isograde 1 is for Gleason 6 disease, isograde 2 for 3 + 4 = 7, and 4 + 3 = 7 is isograde 3. Gleason 8 is isograde 4, and 9 and 10 isograde 5. Obviously, in the past, we used to rely quite heavily on the ultrasound of the prostate and the renal tract. And you can see here, this is the bladder, this is the prostate. Pretty much, you don't see a lot of anatomical definition in the ultrasound itself. Whereas when we look at the MRI, you can see quite nicely delineated zonal representation of the prostate. So this is the peripheral zone. You can see it nicely here. This is the demarcation of the transitional zone, the fibromuscular stroma, and the central zone of the prostate. So this is a normal MRI that you would see, and this is the urethra here going through the membranous part of the urethra, and this is the external sphincter. So you can see how nicely we can see now these structures now on MRI. So if you look at the multiparametric MRI, there are different things that we look in the multiparametric MRI, including, so where is, do we find any cancer? Where is that location of that cancer? Is there any potential extracapsular extension, which does make a big difference in terms of what we do during the operation, whether we do a wider excision of the neurovascular bundle on that side. So we're looking at bladder neck, whether we can do bladder neck preservation, and looking at also the urethral length, which we saw in the previous slide, because it does make a difference in terms of continence of the patients. So in terms of the watchful waiting, also it's important to know that whether these lesions are quite significant lesions, and sometimes even if you do a biopsy, for example, and it shows a Gleason 6 disease, if you're going to practice watchful waiting, MRIs also takes a significant, important role. So if you look at the multiparametric MRI, it looks at all the different parameters, including T1, T2, diffusion, and ADC, and it does give us a much better prediction then in terms of predicting whether these patients have got cancer of the prostate. And as you can see here, this is from PIRADS 1, PIRADS 2 here is this linear lines in here, which is geometrical lines. This is a PIRADS 3 abnormality, which is equivocal, and then you look at PIRADS 4, and that's PIRADS 5 here. So PIRADS 5 is quite significant, involving the capsule of the prostate, but potentially here. You can still see the delineation and the line of the capsule, but very likely that that capsule is involved. So you can see the spectrum of the PIRADS scoring system in this one, and this is only on T2. If you look at the other forms of the parts of the MRI, for example, here is the diffusion, and this is ADC. So if you look at diffusion here, it looks very bright, and ADC, it looks a darker spot here. And the ADC and diffusion are almost like the old-fashioned black and white photos, the positive and the negative. So you can actually match the two, and then it does confirm the findings on the MRI. You can see here, for example, this is a PIRADS 5 lesion, and on a PIRADS 5 lesion, quite an extensive anterior tumor there, and the peripheral part of the prostate here. This is the rectum in this area here. This is all clear. And you can see that very nicely here on the ADC, it looks dark. So when we look at the MRIs, PIRADS 4 and 5, obviously, these are more serious lesions, whereas PIRADS 3, it's equivocal. And if you look at PIRADS 3, when we talk about the patients, whether we do a biopsy or whether we do a more active treatment and active surveillance, more lately we've been using the prostate health index to try and determine in certain group of patients for PIRADS 3 lesions, which are a bit more difficult to see whether they're potentially whether we should do a biopsy. We do a prostate health index, and prostate health index then will guide us more towards either active surveillance and more PSA testing, or that we proceed to a biopsy of the prostate. Usually with PIRADS 1 and 2, this is obviously dealing with benign disease, and the risk of cancer of prostate is low. However, sometimes we do find that a PIRADS 2 abnormality, actually there is a significant tumor present, and sometimes I refer to this as radiology fatigue. They do see quite a lot of MRIs, and sometimes they might not pick up a lesion that might be a bit more obvious on on a T2 examination. And if you have a rising PSA, and if you have a high prostate health index, then these patients, we've been biopsying, and quite a few of them, we actually do find that they are positive for cancer. So there are certain other tools that we might need to use to try and diagnose the cancer of prostate. This is obviously the previous biopsies that we used to do with an ultrasound guided biopsy. And you can see here, sometimes if we got the edge of that lesion, you probably would get a low Gleason score, and sometimes you had overrepresentation of that lesion, where we actually sort of landed 2 or 3 of those biopsies in this area. Now with the targeted biopsy, where there's different forms of targeted biopsy. One is the in-gantry, and this is the in-gantry biopsy here. We're putting a probe inside the rectum, and this is the lesion here. So with the in-gantry biopsy, we can hit the target more accurately. We've done quite a few of these biopsies, probably close to 300 of these biopsies, but because of the nature of being in gantry, a lot of the time to be used inside the machine, and the actual biopsy needles being had to be MRI proof. We moved away from that to more the fusion biopsy system. And you can see here, this is the fusion biopsy system. What we're doing here is we are marrying the MRI with the ultrasound, and you can see the lesion here on the ultrasound. You can see the lesion on MRI, and this is where the track of the needle will go through when we do the biopsy. And you can see the actual needle here. We've taken samples of that biopsy. And more lately, we've got now 400 cases or more of the perineal guided biopsy. Again, it's a fusion guided system. The reason why we've moved towards the perineal guided biopsies is because with the transrectal biopsy, there's been an increase in number of resistant bugs that we had to deal with, and the septicemia rate has been higher, even though in Canberra our septicemia rate has been actually low, about 1%. With a transperineal biopsy of more than 400 cases that in my series that I've done, we've had so far, touch wood, 0 infection rates. And this is obviously because you're putting the needles through the skin rather than through the rectal area, but you still need to use the ultrasound to image the area. And we're also doing the fusion system. So we actually pre-plan the lesion. And you can see here, this is a typical biopsy that we would do. You can see this is the lesion that was planned. This is the abnormality on the red here. And that's where we've done the biopsies. And we can actually map it. We can store these maps. So if we need to go back and do a check reference to where the biopsies were taken, we can still be able to do that. So obviously, this is in-gantry biopsies. If you have to do them under anesthesia with a perineal grid, it's not very practical. You need to have an anesthetic, and they need to be in this kind of a position, which is really not a very practical way to do it. So that's why we've moved away from that. So PSMA PET scans have been a great thing that has helped us in really diagnosis, staging, and in my practice also I use PET scans for active surveillance. We'll talk a bit more with Patrick Bowden also with the PET scans, because we also do the PET scans for patients that have had recurrence of cancer of prostate, and he's got this super duper machine in Melbourne that we've had also some of our patients that have had a earlier PSA recurrence, and we've got Patrick to do the PET scan down there. So it's a tool that we've been using now for the last 7 years in Canberra. We've been lucky. We had very early access to PSMA PET scans. And now that they've become also rebatable, it's now been a routine. We've given away now bone scans as such, and PET scans have really taken its place. So in terms of the, I think I'll probably leave some of this to Patrick. This is the images that you can get on the PSMA PET scan, and you can see the lesion down here on the prostate. This is the ureter here. This is normal physiological. You can see also the liver lights up, and also the parotids. Now you can see here in a normal CT scan, you don't see the lesion here, but on a PET scan here, you can see a lymph node here, which is positive, and you can see the lymph node there. So again, so it has become very useful in terms of treatment, and also has been a change of practice from our perspective, is that I certainly have stopped doing now lymph node dissection, which we used to do. And now if there's any recurrence after the radical prostatectomy, I will get past those cases on to Patrick to do stereotactic treatment, which Patrick will discuss later on. And that's a lesion, for example, that you can see here on the bone in the pelvis. And a few other scans. So I think probably I'll pass on from this point of view to Patrick with the PET scans. Now, this is the lesion, for example, you can see here on the prostate. And now this is very important for us to know where the MRI, where the lesion is, because you can see that the peripheral zone here is quite clear. And when we do the radical prostatectomy, we can preserve the neurovascular bundle, which is down here and on the side here. So also it's important to check the actual lesion, where is it in relation to the bladder neck, because bladder neck preservation is quite important. Obviously, you can see here the robot. This is my favorite tool that we use. It's nice, it's precise. I've done now more than 900 robotic prostatectomies, including partial nephrectomies and also simple prostatectomies. When we talk about simple prostatectomies, this is instead of doing a TURP using the laser for patients that have got very large prostate, we will do a simple enucleation of the prostate, what it used to be called as Millen's prostate surgery, or simple prostate removal of the prostate. So I won't go through this side because in terms of time of interest, this is what we don't want to see as a group. And this is all of us in oncology, we want to try and avoid cases with metastatic disease. Neurovascular bundle, you can see here, this is important. You can see that the bundle is not actually a nerve in its own. You can see that it's a branches of nerves, which is a nervous plexus that passes on the posterolateral part of the prostate, and that's what we have to try and preserve when we do the procedure. And 50% of the time, patients will end up being able to have erections after radical prostatectomy. This is a tumor here at the bladder neck. So in this case, when we do this resection of the prostate, we have to be careful here to avoid any positive margins. And this is a case where you need to do wider resection of the bladder neck and try not to preserve the bladder neck. This is the urethra down here, and this is what we need to try and preserve as much as of this length of the urethra to try and achieve early continence. Whereas you can see in this case, this is the tumor here, so you won't be able to try and preserve the urethral length on this side. You need to go wider for a full excision. Again, neurovascular bundle, you can't preserve on this side, but you can come very close on this side. So in this side, maybe you can do an incremental nerve sparing. So this is the tools that you have to use to try and make sure that the surgery is individualized to the particular patient, which is very important to get good outcomes from the patient's point of view. You can see here, this is involvement of the capsule of the prostate. So in this case, definitely you have to go wider. You have to sacrifice the nerve also. And in this particular case also, you have to be careful that it's not involving a bit of the pelvic floor muscle, which is down here.
Hodo, that's 20 minutes.
Well, I think I'll probably stop there. And if there's anything else, I think we can probably answer some of those questions afterwards.
Fantastic.
Thank you so much, Leonie.
Thanks. That went very fast.
It does.
It does, doesn't it? Sorry to cut you off there.
No, it's okay.
So our second speaker tonight is Dr. Patrick Bowden. Dr. Bowden has 20 years experience as a consultant radiation oncologist. He's a leading specialist in the use of intensity modulated radiation therapy and stereotactic radiation therapy for treatment of early metastatic disease. After establishing his radiation oncology career at Peter MacCallum Cancer Centre, he became the director of the Tattersalls Cancer Centre in 2007, the private arm of the Peter MacCallum Cancer Centre. In 2011, he was appointed as the inaugural director of the Epworth Radiation Oncology Unit. He's been treating Canberra prostate cancer patients for over 10 years and for the past 5 years at the Canberra Icon Cancer Centre. Thank you very much.
Thank you, Leonie, and thanks for the opportunity to talk. I'm going to give a fairly brief talk tonight just to go through the changes and advances that have occurred in radiotherapy treatment for prostate cancer just over my career, and those treatment advances that are now available for patients in Canberra. So radiotherapy has been used for prostate cancer for many, many decades, back to the 1950s. But was a fairly ineffective treatment up until really the late 90s. And there's been a massive improvement, though, in that time since then, mainly due to enhancements in IT and in computers and in imaging and the software that we use to plan radiotherapy, as well as some improvements in equipment. And to give you a bit of perspective on that, so when I was a registrar back in the 1990s, when we were referred a patient for radiotherapy for primary prostate cancer, we effectively had to guess where the prostate was. So this is how we treated a patient. We would take an X-ray, and this is a lateral X-ray of a patient's pelvis. You can make out the top of the acetabulum there. Oops, sorry. Can you see my cursor moving there, Leonie?
Yeah, we could see that. Yep.
Right, okay. So you can make out there, you've got the top of the acetabulum, you've got the pubic symphysis there. And so we used to just take a guess and say, well, we think the prostate's somewhere around there, so we'll draw a radiotherapy box around like that. We'll maybe, for cosmetic reasons, chop out some edges of the radiation field to try to protect normal tissue. But it was a bit of a hit and miss affair. And so we were giving moderate doses of radiotherapy to these targets. And you've got your rectum coming through here, you've got your bladder sitting down here. So we used to give fairly hefty doses to those normal tissues, those normal organs, which resulted in fairly significant side effects and potentially horrendous side effects in some cases, which gave radiotherapy a pretty bad rap and probably justifiably so. But we were, because of these big fields, we were limited in how much radiation dose we could give because we were worried about really cooking those organs. So that resulted in the radiation cure rates being relatively low because of the poor doses that we were using. And then in the late 90s and into the early 2000s, we moved away from that sort of planning from radiotherapy treatments, which we call two-dimensional planning, to three-dimensional planning. And three-dimensional planning, basically, we went from taking X-rays to CT scans. So we would get a CT scan of a patient's prostate area, and this is obviously an axial CT, and we would mark each CT slice, each few millimeters, actually mark out the prostate, mark out the bowel, to try to create a bit more of a conformal approach to treating the prostate and try to reduce the amount of normal tissue we were treating. And that gave us these more refined radiation fields that were adapted to the target, this being the prostate here and the rectum here, trying to exclude as much of that as possible. So that was a big improvement. That enabled us to increase the doses of radiation somewhat, but we were still catching a fair bit of the bowel and the bladder and causing undue side effects. We then, in 2005, I started using a new technique called IMRT. So this is how a three-dimensional conformal radiotherapy field looks using that example on the previous slide. You've got your prostate here, you've got your bowel here, you've got your bladder just tipping in anteriorly. But those radiation fields were very geometric, straight lines, which didn't really conform to the natural anatomical shape of the prostate and the organs you were trying to avoid. So this new treatment technique was developed called intensity modulated radiotherapy, which was basically born out of huge advances in software that enabled the radiation machine to produce attenuated beams that effectively produce curved radiation doses, as you see here in yellow. So that was a big advance that took us over the next 5 to 10 years of radiation treatment for prostate cancer and really enabled us to escalate the doses to the levels we're using now and dramatically improve the cure rates, but at the same time not increasing the risk of damage to bowel and bladder. We then went one step further about 10 years ago with the use of what's called image-guided radiotherapy. And the reason we use that is because we know from one day to the next, when you're having, say, a 4, 6 or 8 week course of radiation, the prostate can move slightly from one day to the next, depending on the filling of the bladder and the bowel, and there's other variables there as well. So we wanted to have a way of adapting the radiation field each day to compensate for that movement and therefore reduce the margin of radiotherapy we would have to use ordinarily to allow for that movement using our old-fashioned techniques. And a fairly simple technique was developed. We would get our urologist friends to implant 3 gold pellets actually into the prostate using a transperineal needle and a very light GA. And then on a daily basis, when the patient was having their prostate radiation, we would take X-rays from different angles. We would get those coordinates in three-dimensional space and retriangulate the beams each day to the new position of the prostate. And what that meant was we could then reduce the margins around the prostate, the radiation margins around the prostate even further, and therefore, again, limit the amount of radiation received by the bladder and bowel. The final step in I guess, perfecting radiation treatment for prostate cancer is the use of spacing gel. So if you look at just, again, a lateral picture of an approximation of your prostate here in purple, bladder in green, rectum in yellow. So it doesn't matter how much you reduce the radiotherapy field margins around the prostate, you're never going to avoid hitting at least the anterior part of the rectum there because it's in direct contact with the prostate. There's a small fascial plane, but for all intents and purposes, there's direct contact. So we worked on a new technique where we would actually physically separate the prostate from the bowel using a gel, a liquid gel. And here's an example on an MRI of the prostate here, bladder here, and bowel here, with complete separation of the anterior bowel wall from the prostate by this water-based gel. It's called spacer gel, or Barrigel is the other version. So this has been a huge improvement again in the radiation side effect profile. And I was lucky enough to be the associate investigator on the largest trial done on this in 2015, where we treated 70 patients in a phase 2 protocol to assess the actual long-term benefits of using this gel. And we published our long-term follow-up a few years ago. And of the 70 patients we treated, there was no long-term high-grade toxicity involving the bowel. There were 2 perforations of the bowel post-insertion of the gel, which we think was related to more pressure necrosis than anything else. And we've learned from that. And I'd have to say now, and touch wood, but we've, I think, done well over 100 insertions now in Canberra, and we've not had a single rectal perforation. So if we just look at the toxicity profile from that study, going from baseline through to 4 and 5 years post-treatment, and we look at all the bowel domains, there is essentially no change in patient toxicity or quality of life throughout that whole period. So we've now made that the standard of care. And so all of those progresses that have occurred since a fairly primitive 2-dimensional conformal approach to treating prostate cancer have all actually occurred in my career, which is quite phenomenal. And I often say this is akin to comparing surgery in the 1800s to surgery now, that the advances that have occurred in the treatment of prostate cancer with radiotherapy over that relatively short time. So I'm now going to move on to the treatment of metastatic disease with high-dose radiotherapy, what we call stereotactic radiotherapy, for a particular subset of metastatic disease, what's called oligometastatic disease, which has really become an area of intense research over the past decade because of the stunning results that we're seeing in prostate cancer and in all cancers in general for treatment of early metastatic spread. So it's what we call metastasis-directed therapy for oligometastatic prostate cancer, which is taking an ablative approach, be it surgically or radiotherapy, for patients who have technically incurable stage 4 cancer. And in order for that to be a successful approach, you have to be able to prove that, firstly, you can diagnose that you have a treatment that's successful and able to ablate the early metastatic disease, and you have to see a clinical benefit, be it prolonging survival or delaying the progression to potentially more toxic systemic therapy. All of the sort of ducks have come together in a row over the past 10 or 15 years to support the use of this approach with stereotactic radiotherapy. So firstly, do we have a viable treatment technique to ablate early metastatic disease and do it in a non-toxic way? And we certainly do now. So if we look at your standard approach to radiotherapy for patients with metastatic prostate cancer, and the typical location is in the lumbar spine. So this is how a radiotherapy approach would traditionally have occurred. You may have a metastasis in the vertebral body here. The way we would treat that palliatively would be to give a radiation field coming in posteriorly. The way radiation treatment works, the dose falls off as it's absorbed by tissue. So your dose actually peaks around here, well short of actually where the metastasis is, and then falls off. So you're actually getting a lower dose on the metastasis than you are around here and around the spinal canal where you don't want it. So that's not a great approach, and that's why it's only traditionally been used for palliation. But we've developed these new techniques called stereotactic radiosurgery, and I won't bore you with the technical details, but if the effective outcome is that you're able to give very high doses of radiation and shape them perfectly to the target. So let's say in this case we've got a metastasis involving the posterior elements of this thoracic vertebra here, and the high dose radiation line is this lime line here. So that's shaped perfectly to the contour of that posterior arch, and of course missing the critical normal organ here, which is the spinal cord, which if it's damaged by radiation results in paraplegia. So we're now able to give ablative or killing doses of radiation to these metastases, but not cause any long-term damage. So that's the first box we need to tick in order to take this approach, this ablative approach for oligometastatic disease. We now have a technique that's effective and safe. The next thing is, do we have a biologic rationale? I mean, what's the point of treating stage 4 cancer, even if it's early? Because the teaching has always been that once someone's got metastatic disease, then it's everywhere. And we always had the belief when we were taught that if we look at this case here, case A, of case of a man with prostate cancer who's got metastases in multiple locations, we typically thought that, well, all of those emanate from the prostate primary. So if you've got some that have emanated, there's going to be multiple emanated around the body. But that was all confounded by numerous studies, including this one, which published in Nature 9 years ago, which was a very brave study for the participants. It was a group of men who agreed to have multiple biopsies, including bone biopsies, of their metastases. And all of those metastatic sites had chromosomal analyses done to determine which was the initial lesion of origin. And what some of these patients and biopsies confirmed is that in some cases, all of the metastases, as is the case in green, emanated from a single metastasis. So the prostate primary would have spread to here, and then from that site there, all the other metastases were seeded. So this was crucial information. What this tells us is that in some men and some cancer patients in general, if you can identify very early metastatic spread, you may be able to stop the whole metastatic cascade from occurring if you can get rid of that initial metastasis. So that was key information that again, enabled us to push forward with this metastasis-directed approach to treatment. The next box that needs to be ticked is, do we have a way of detecting early metastatic spread so that you can actually action treatment? And fortunately, again, in the past 10 or 15 years, the stars have aligned and new techniques have developed to image prostate cancer. And Hodo's already touched on this with PSMA PET scanning. So basically what PSMA PET scanning is injecting patients with a ligand that binds to a marker that's found on the surface of most prostate cancer cells, and attaching to the other side of that ligand a radionuclide, so that where there's an accumulation of the ligand, you get a hotspot, and that tells you you've got a metastasis. And to show you how that compares to our traditional imaging, so when patients had a PSA relapse of their prostate cancer after having their prostate removed, we traditionally did a CT scan and a bone scan to try to find where the cancer had spread. And in most cases, when the PSA was below 10, you'd get this. You'd get a CT scan and you wouldn't know if there was any metastatic spread there. But when you see that patient with a PSMA PET scan, you've got that hotspot there. It highlights perfectly that, in fact, that is a metastatic node. It's only a few millimeters in size, but you're able to pick it very early with PET scanning. And we've now, as Hodo again touched on, we've now got a PET scanner in Melbourne that for patients with PSAs less than 0.2, it's detecting the site of recurrence in 2/3 of cases. So we're really catching these patients in their advanced, their spread or progression or recurrence of their cancer at a very, very early stage now. And finally, well, while we do it, we've got a good backup treatment, if you like, with hormone therapy for prostate cancer. It's extremely effective. I'm sure Neha is going to talk about it in more detail. One of the most successful treatments there is for cancer in general. Hormone therapy for prostate cancer has got a close to 99% success rate, usually over a multi-year period. But it does have toxic effects. Obviously, it's equivalent to castration. So you got, when you go from high testosterone to low testosterone, things don't look as good. You get obesity, you get osteoporosis, you get mental effects, and you get, of course, the obvious erectile dysfunction and loss of libido. There's also concerns about worsening of cortical diseases, Parkinson's and dementia, and some studies show that there's an increased risk of cardiac events in men who are on long-term hormone therapy. So if we can delay this, we're certainly doing men a favour, even if we don't result in any improvement in their overall survival. So based on this rationale and some early experience I had with stereotactic radiotherapy in men in this situation, we set up a trial at the Epworth to treat men with stereotactic ablative radiotherapy for up to 5 prostate cancer metastases. And this was how I got involved with the team in Canberra with Hodo and Dr. Pranavan. We set up this trial in 2014 and they got wind of it and started sending a significant number of Canberra patients down to participate in this trial. So the trial was basically, of course, for men with confirmed prostate cancer histologically who had 5 or fewer metastases. And it ended up being, and still is, the largest prospective trial in the world using a metastasis-directed therapy for prostate cancer, for oligometastatic disease. So we've just published our long-term follow-up on the 200-odd patients we treated. And the key findings were that after 5 years, about a quarter of the patients and nearly 20% of the patients after 6.5 years had not required any hormone therapy or other form of therapy. So this is important because this is all men who have stage 4 metastatic prostate cancer, and a significant, meaningful number of those men do not need any other treatment if they undergo stereotactic ablation. We also found that there was no long-term toxicity with the approach, so quality of life is excellent. And the interesting finding was that men who had the upper end of number of METs, 4 or 5 in the trial, had the same outcome as men with 1 to 3 METs, which was an interesting finding, which will have to be explored in other trials. Furthermore, there's the potential we've got a few cures. So we're out to, I think, 8 years on our patient who's got the longest follow-up with a 0 PSA. So there's a real chance that a few men can actually be cured of metastatic disease. And there's pretty much no other data in the world on any trial showing a cure of men with metastatic prostate cancer. So this is very interesting data that we'll be following up individually on those men who've maintained long-term 0 PSAs to see if we can identify any other prognostic factors that would have potentially predicted that. There's been other trials since my trial that have looked at a randomized approach. So my trial was a single-arm phase 2 trial, but randomized trials obviously the most definitive in terms of determining a long-term benefit. So there was a Canadian trial called the COMET study that randomized patients with up to 5 metastatic sites with all cancer. So this wasn't just prostate cancer, this was all cancer: breast, melanoma, lung, colon. And they randomized those patients to either standard of care, which would be systemic treatment, versus standard of care plus stereotactic ablation of their oligometastatic disease in a similar fashion to my trial. And what they showed with 5-year follow-up was a dramatic improvement in 5-year survival in those patients who had stereotactic ablation. And the difference at 5 years was 17% in the standard control arm versus 42% in the stereotactic arm. So more than a doubling of 5-year survival. And to put that in perspective, I'm sure Neha will be able to comment on this, but if there was a drug that could produce this sort of long-term benefit, it would be probably the most expensive and most valuable company in the world. This is a stunning improvement that the likes of which we rarely see. So this has really confirmed what we've sort of known along the way, that this treatment works, and it's really changing the whole paradigm of treatment for patients with early metastatic cancer, and of course particularly prostate cancer. And this was just some quality of life analysis as well from that trial, showing there was no toxicity of any note in the patients who had the stereotactic treatments. So what I'd like to do in conclusion, and finishing off, is just to talk to you about the case that got me first involved in this line of treatment. Patient was referred to me at the age of 53 back in 2007. He'd recently had a prostatectomy with Professor Tony Costello, revealing Gleason 7 disease. PSA was 38 preoperatively, so a very high risk patient, but his preoperative bone scan and CT showed no metastatic disease. So he went ahead with his prostatectomy, but within 6 months of that, his PSA was back up to 52. So he was in a bit of trouble, and he developed some low back pain. So he'd had a bone scan, which just showed this quite large but solitary L4 bony metastasis. And he was referred to me by Professor Costello, who said, look, this guy's young, he's only got one side of disease. We're going to give him hormone therapy, but why don't you just try giving this high-dose radiotherapy, which was a completely foreign concept. We'd never really thought about that before. We didn't have stereotactic capability back then. But I gave him a moderately high dose using an IMRT technique. And he went well. He had the hormone therapy, and his PSA dropped to a low level after the radiotherapy, but that, again, could have just been the hormone therapy. But then he developed hormone refractory disease about 5 years later, which is a bad prognostic sign. Again, Neha will probably talk about this, but his PSA rose up to 8.5, and he had another bone scan, which this time showed just a solitary iliac bony metastasis, and his L4 lesion had been ablated. So an unusual situation. He had hormone refractory disease. We would have expected more metastatic spread. But because he'd done so well with that initial treatment and had limited disease, we gave him stereotactic radiotherapy. We had the capacity to do that at that stage. And to cut a long story short, I saw that patient earlier this year, 17 years later. He's now had 7 courses of stereotactic radiotherapy periodically over the years, each time a metastasis pops up. And his PSA is on the decline, and he's not had any hormone therapy for 2 years. So he's actually on a break from hormone therapy now 12 years after being hormone refractory, which, again, I'm sure Dr. Aggarwal will talk about the stats on that, but the likelihood of that occurring is about 1 in a million. And so this patient has never had chemotherapy, never had second-line hormonal therapy, never had some of the newer anti-androgens. So we think we're now seeing the potential to turn metastatic prostate cancer into a chronic disease rather than a fatal disease. Now, that patient is an anecdote, but he just happens to be the first patient I ever treated, and he's still going strong 17 years later. So that's the hope. That's where we think things may be heading for a certain cohort of men with metastatic prostate cancer, but it all comes down to, of course, catching them early and giving them the right treatment.
Thank you very much. That was just really interesting and just amazing to see how things have changed since your kind of very foggy X-ray image at the very beginning. So our third speaker for the night is Dr. Neha Aggarwal, who is a medical oncologist at the Icon Cancer Centre in Canberra. Dr. Aggarwal undertook physician and specialist oncology training in Australia, including a 2-year fellowship in early phase clinical trial and drug development at the Kinghorn Cancer Centre in Sydney. She has a strong passion for clinical and translational research and has clinical experience covering a broad range of solid tumour malignancies, with a special interest in thoracic malignancies, including lung cancer and mesothelioma, genitourinary cancers, including prostate cancer, renal cell cancer, bladder cancer and testicular cancer, breast cancer, and central nervous system malignancies. Thank you, Dr. Aggarwal.
Thanks, Leonie. I'm just trying to share my screen and having that issue.
Yeah. So while Dr. Aggarwal's sharing her screen, just a reminder to type all your questions into the Q&A box, and we'll have the panel discussion at the end of the presentations.
So I've lost the button for the share, like the share one. Is Kunal?
It's
Yeah, it's not coming. It's coming
yeah.
as.
Have you got your Zoom screen at the very bottom? You can see mute, stop video, participants
Yeah.
Q&A, chats, share screen. The
Yeah,
green.
share screen, but it gives me the option of multiple panelists can share simultaneously. But
I will get Kunal to help you out with that
Yeah,
one.
you have to just pick the PowerPoint presentation. You click on the PowerPoint presentation, and it'll show up. And then share down the bottom right of that panel.
Neha, when you share, click the share button, what can you see?
one panelist can share or multiple panelists can share.
Just click on one panelist can share.
Yeah. I click that. You can't see my screen, isn't it?
We can't see.
Do you like Kunal to do the slides for you, and then you can just say next?
Yep.
Possibly while we're waiting, we might just flip things around again. And Greg, would you like to speak? And then once we've sorted out Neha's screen after you finish speaking, Neha, you can go. Would that be okay?
Yeah, sure.
Yeah.
Yeah, that's fine. Leonie, I'm happy to step in here if that's fine by you. So if I can just start off and just introduce myself. My name is Greg McRoberts. I'm, I guess, a lived experience of prostate cancer over the last 20 years. I'm also the leader and member of the ACT Prostate Cancer Support Group. I'm also an advocate with the Prostate Cancer Foundation of Australia, who is our peak body for prostate cancer here in Australia, and also an advocate on their Life Force program, which is the opportunity to go out and educate men about prostate cancer and the benefits of early detection. I guess one of the things I'm very keen tonight to do is to really push the banner of early detection. We've spoken a lot tonight with the previous presenters so far about the treatments and metastatic prostate cancer. I was fortunate a couple of years ago to be able to do a presentation at Parliament House in front of all the leaders of the various parties and members of Parliament, and basically called on people to essentially denounce prostate cancer as being an old man's disease, and rather view it as perhaps a disease that has been basically, unfortunately, diagnosed too late for far too many, for far too long, resulting, I believe, in a lot of the obviously metastasized prostate cancer that a lot of these wonderful clinicians are out there treating and helping to improve the quality of life of these men. My own personal experience was that I was diagnosed at the age of 46. I'm now sort of halfway through my 66th year. I started out with having some blood tests done for other reasons through my GP, and him giving me a call and saying I needed to come back in and have a chat to him about this PSA level, and had no idea what PSA was, had no idea what my prostate was, had no idea of the relationship of any of it, to be totally honest, totally ignorant, as probably a lot of men are. Now, what happened was I was referred then to a urologist in Canberra. And as a result of that, at the time, at the age of 46, I was one of the youngest or the youngest man that particular urologist had ever dealt with. So as a result of it, I went on quite an extensive antibiotics program for 6 months. Because I guess at that time, he just couldn't believe that it was possible at that age I'd have prostate cancer. The end result was essentially that from the period of my initial PSA test, which was around about 3.8, over a 6-month period, I jumped up to a PSA of level 8. I was then referred. I then went on to do a biopsy, which then confirmed that I had prostate cancer. And at the time, back then, not quite the opportunity, I guess, to look at the range of opportunities for treatment or surveillance that we have now. So being of that particular group at that particular time, clearly I saw it as cancer. I just wanted it out, right? So I underwent a radical prostatectomy and came out through that. I was very lucky at the time, for whatever the reasons were. Don't remember having any leakage of bowel issues. I had no incontinence whatsoever post my treatment, and certainly had some issues whilst having had some nerve sparing, had some issues with erectile function, and that took me about 2 years to resolve, and generally without any other sort of follow-up treatments or assistance, because again, at that particular time, there just wasn't any references to those sorts of services or other things that I should have done. So I came out after the prostate cancer, went for about 7 years, essentially had an undetectable PSA level, got to about 7 years post my treatment, and finished up with on what was supposed to be my final PSA test, where I guess I probably would have looked at being in remission, and my PSA just kind of rose its head. I think it was about 0.01 or something at that particular time. So I kind of went through, I guess, another 9 years, I suppose, which now would probably be referred to as active surveillance, where my PSA showed some signs over time of steadying increases. It resulted in about 16 years post my surgery, where my levels had gone basically up to a level of just over a level of 0.1. And then in the next 12-month period, I went from 0.1 to 0.24 with my PSA test. I was referred at that point to radiation oncology here in Canberra at Icon. Fortunately, being a ex-services, I found out I was able to avail myself to a to DVA assistance and went to Icon. About 36 doses, if my memory serves me correctly. I came out after that treatment. It took some time. My levels sort of came down to, relatively low levels. I'm now about 3-4 years post that radiation treatment. And I'm now in a situation where in the last 12 months, my levels have now gone again from about 0.01 up to about 0.03, and that doubled really went up by that amount within about a 6-month period. So I'm currently away at the moment doing some things in Port Macquarie, but when I get back to Canberra, I'm due for another PSA test to see whether it's still stabilised or whether I move on. So the message that I'd like to relay, particularly to those of you that are online with us tonight, for the GPs in particular, is that early detection has given me the best possible outcomes. You know, as I said, I'm now 66. You know, generally, you know, whilst certainly post-radiation, in the last 4 years, I think that I have found a certain loss of libido, but, you know, my partner and I have always worked on the basis that that part of our lives is not the be-all and end-all. You know, so we've worked on other things to improve our intimacy and those sorts of things. I've always been a person that, you know, I really don't take to medication particularly well. You know, I really prefer to avoid it at all costs. I'm probably a believer at that level that whilst I understand that they're necessary and a necessary evil in some case, that all medications generally in some, you know, length of time, you know, have some detrimental effect to your health. So I really have tried to, you know, stay away from all that. I've also been very lucky in as much as during all that process, I've never had to have any sort of ADT, chemotherapy or hormone treatments or anything of that sort of nature. And I think, fortunately, as a result of it, you know, I'm a fairly healthy, fairly able-bodied 66-year-old man that enjoys an extremely good quality of life. I am a staunch advocate for early detection. You know, one of the greatest takeaways from tonight for those of you out there, you know, seeing men is that to be able to talk randomly about, you know, particularly if they're 40 over, in terms of family history, to try and determine whether an early sort of PSA test, you know, makes sense. Certainly in the cohorts that I talk to, in the various group formats and things that I'm involved in, we very much advocate that, you know, over 40, just get out there and have good regular blood tests in general. But hey, if you're uncertain, just ask the GP to do a PSA test and then just monitor it. Because certainly at the moment, it's my understanding that it is still, you know, the best early warning device that we have, particularly if there is a fairly dramatic or, you know, or a doubling of a PSA level within 12 months. And as some of you or most of you would probably be aware, the Prostate Cancer Foundation of Australia at the moment, in conjunction with the large committee, are going through and doing revisions for the testing guidelines for prostate cancer. And definitely I know that their aim is that what we want to do here is increase the opportunity for early detection. And I think that as a goal, you know, we all need to be on the same page and say that through early detection, we have a dramatic opportunity in the future to reduce metastatic prostate cancer. And I think that has to be something that we have to be, you know, all really, really happy to try and do. The other things that I'd like to draw your attention to is that groups like ourselves with the prostate cancer group here in the ACT, and also through the Prostate Cancer Foundation of Australia, we have a number of things that we can offer your patients. So if you get somebody who does come in and they do have an increased PSA and you are referring them on to specialists, is to let them know that they do have local support groups, or they have this peak body that they can contact. And PCFA has an amazing range of services, including telehealth nursing. They have psychologists that can be helpful to guys, and not only guys, but also their families in general. And also that's the benefit that we can offer, is that it's an opportunity locally here in Canberra that you can advise guys to get in touch with us, and they can chat. And certainly my aim has always been that when I'm speaking to somebody, understanding what their circumstances are, their age, where things are at, I generally put an email out to our group, and I try and get somebody who's in a similar position recently, so those people get an opportunity to speak one-on-one with somebody who has a lived experience. And it takes a lot of the negativity, it takes a lot of the rumors out of what prostate cancer really is. And, you know, I think most importantly is that, you know, I think the two key things that I've certainly come across the most is that ED function and obviously incontinence. And certainly when you get an opportunity to speak with a larger range of people, you actually find out that, like, you know, it's not prevalent in everybody. So the opportunity to give that enlightenment and spirit of hope that, okay, this is not going to be the be all and end all of me, and I'm not going to turn into a peeing mass and a man that can't perform anymore in the rest of his life. And I think that spurs people then to go on and do what they need to do. But the key thing here is about early detection, and it's about then being able to do whatever treatment makes sense within the right time frame, and whether that's active surveillance, or whether it's it's some form of surgery, or whether it's radiation, or depending on situations with chemotherapy and those sorts of treatments. So please be aware that we are here, and that PCFA has an amazing website with an amazing amount of resource. So please reach out and get in touch with us if we can be of any help. And as I said, it's key putting people in touch with us. And also importantly, it would be remiss of me not to mention that there's a lot of things going on at the moment with what we call prequel treatment, and that's about getting guys into physiotherapists, into sex therapists, into those sorts of clinical people that can help them understand what they can do prior to their surgery and what they will need to do post their surgery to give them the best possible outcomes. If we can do that, then we can really work together to improve the health outcomes, not only generally of men, but particularly of men that are diagnosed with prostate cancer and need to go on to some forms of treatment. So thank you very much for your time. Thank you very much for allowing me to be part of the panel tonight. And thank you to the other panelists, and just listening tonight with the changes that are going on within the different clinical categories to improve the outcomes of men and men that do have metastasized prostate cancer is just absolutely wonderful. So thank you to all of you for the work that you do to help us and our families in our journeys with prostate cancer.
Thank you so much, Greg, and stay on the panel because I'm sure there'll be questions for you afterwards. So now Dr. Neha Aggarwal, and she's going to talk about the medical management update of prostate cancer.
Yeah, sure. Thank you. Thanks, Leonie, and thanks everyone for giving me this opportunity to share the major updates in the change in the treatment of the prostate cancer. And thanks, Greg, for sharing your story and making an emphasis on telling us to do early screening. But I'll tell you how it's become a bit more complicated from a general practitioner's point of view. So prostate cancer is one of the most common cancer in men in Australia. It's the second leading cause of cancer death, again in Australia. And incidence increases as you increases the age, and lifetime risk of developing a microscopic prostate cancer is around 30%. So I'll come to screening part. Hodo has already touched on the screening part. So it's a PSA is the most common thing which we used for screening, and PSA is a glycoprotein which is secreted by prostatic epithelial cell. It is not a cancer-specific marker, but as such, most individuals with elevated PSA and do not have prostate cancer. However, if you have increasing PSA, you can have prostate cancer, but there is no estimated level where you can say if you have below the PSA of this level, there is less risk of prostate cancer. Next, please. And there is a prostate cancer prevention trial which has shown if a total PSA level is greater than 10 nanogram per milliliter, then there is a 67% chances then they can have biopsy-proven prostate cancer. However, the patients who had less than 4 nanogram can also have prostate cancer. So you can see that you can't really see that who will benefit from doing a PSA and early and can give us an early detection. So we really don't know when and who and how we should do this PSA, and it's become a bit more complicated recently when Medicare has put a charge against doing a PSA for the patients who do not have prostate cancer, and they have to pay around $70 if it's ordered for a surveillance reason. Next slide, please. So For Royal Australian College of Guidelines, screening guidelines at this stage, their statement is the screening of asymptomatic or low-risk man, and I'll explain who are the high-risk man, for prostate cancer by prostate-specific antigen is not recommended. And general practitioners have no obligation to offer prostate cancer screening to asymptomatic men. But there is a huge role of general practitioners in, next slide please, in ensuring that there's awareness of the prostate cancer in the man. Can I have a next slide please? So we should, general practitioners should have a bit of knowledge around whom to counsel then, or who are at higher risk. So we should make a individualized risk plan for a patient more than 50 years and who has a life expectancy of more than 10 years. And there are some high risk groups like a patients more than 45 years with a family history of prostate cancer, or with high risk ethnicities like Afro-Americans, or the patients who have got BRCA2 gene mutation running in their families. Patients who have less than 10 years of expectancy should not be offered a PSA screening. So because of all the billing issues, or we really don't know who is going to benefit, we need to talk and discuss with the patients that what's their family history, how we're going to interpret this test, how often we're going to monitor the PSA, and what's their risk factor. And then we should develop a plan for them and then order a PSA and further investigations. Next slide. So as you can see, I'm the last speaker, and I usually come in the last stage of the prostate cancer when it has become a stage 4. So either the patients are referred to me when they are stage 4 from got the get-go, which is called as de novo metastatic prostate cancer, or they have had prostate cancer, like a local prostate cancer for which they have had radiation or surgery, and their PSA was undetectable and then started to rise, and then they get referred to me. Either if they are progressing on a treatment, or they have not had any treatment for their early prostate cancer, and now they're referred to me, and there where I come into the picture for treating their prostate cancer. Next slide. So metastatic prostate cancer, I divide usually in 2 types. It's a hormone sensitive, where the patient has never had any treatment and they're still responsible to androgen deprivation treatment, or insensitive, or called as castrate resistant, where they've had androgen deprivation treatment for a few years, but now there's a still rise in PSA despite the treatment, or and we can see by progression radiologically, or there's a new metastatic appearance, or their PSA is still rising despite they are having the androgen deprivation treatment. And advanced prostate cancer usually present with a multiple bony metastatic disease, or it can also present with a visceral disease, a disease in the liver or lungs or the bone, and we call them as a high volume disease, and they usually require treatment quite on an urgent basis. So androgen deprivation therapy remains the mainstay of the treatment. And what does ADT do? It reduces the level of the testosterone in order to prevent the prostate cancer cells from growing. And it's usually either we use this androgen deprivation treatment sometimes in an early stage prostate cancer, when they're higher risk and they require treatment for 2 years, or they have recurred after radiation or surgery. And it is the mainstay of the treatment when they are metastatic or the stage 4 prostate cancer. There are 2 types where we can achieve the androgen deprivation, either by doing a surgical castration, which is usually not done these days, or we usually use the medical androgen deprivation treatment, which is a LHRH agonist or antagonist. So LHRH agonist, next slide please. It's a medication where it is stimulating the anterior pituitary and increases the LHRH, and then it creates a negative feedback to hypothalamus, and in turn it suppresses the production of LH and testosterone. So it's directly acting onto the anterior pituitary and then giving a negative feedback to hypothalamus. And in GnRH antagonist, next slide. it binds to the receptors in pituitary gland, and then it reduces the LH and causing the body's androgen levels to drop. And as you can see, it's directly reducing the suppression of FSH and LH, and does not lead any flare. And these are the medical management we use. And when the patient's present with the stage 4 prostate cancer, we give them a GnRH antagonist and get their PSA quickly down. Next slide. So there are different forms of, you've heard in the community, like Zoladex or Eligard or Leucrin or Digarylex, and they come as a subcutaneous or intramuscular implants, and they come in various durations, like a monthly, 3 monthly, 4 monthly, or 6 monthly durations of the androgen deprivation treatment. Next slide. So I think Patrick has alluded to that androgen deprivation treatment does come with lots of side effects. The main side effect is the hot flushes. It does make men go in a menopause, and it develops almost immediately. It does get better with the time, but this is the most common side effect. We see it in our clinic, and it's quite difficult to manage. Even if you stop the treatment and do intermittent androgen deprivation treatment, it is still a very common and long-term side effect. You do see their energy and their fatigue level increases. There's a risk of developing osteoporosis if you are in a long-term androgen deprivation treatment. There's a loss of libido and erectile dysfunction, and it can cause some issues with their memory, causing more cognitive issues. It does make them weight gain, and there's a risk of metabolic syndrome, including a cardiovascular, and risk of developing diabetes with a long-term ADT. Next slide. So I'll just go through a case and then take through side effects and new developments. So this is a case with a JM in 2015. I saw him. So he's a 65-year-old man who's a journalist, and he's still working part-time. He presented with a few weeks history of back pain and intermittent lower urinary symptoms. Otherwise, he's quite fit and well with no other comorbidities. And his family history is significant, with his father having and mother having a father and uncle having a history of prostate cancer at the age of 65 and 70. So he was seen by a general practitioner in the community, and so we can have next slide. And then the baseline bloods were included, and appropriately, I would say, a PSA was arranged. And then he had a bone scan, a CT scan, because he was having a back pain. A PSA was found to be 56. He was referred to a urologist who arranged for the investigations, I believe, including MRI, and a prostate biopsy was done, which confirmed a prostate cancer with a Gleason score of 4+4. So next slide. So now we have established that James has a stage 4 castrate sensitive, because he hasn't had any treatment, a de novo metastatic prostate cancer. So because it was in 2015, so he was commenced on ADT. That used to be a standard treatment, and it was quite effective. From PSA has come down from 56 to 12 to 1.8 over the few months, and his back pain improved, and he was able to maintain good quality of life. However, after 3 years, he started experiencing a rise in PSA, and his rib pain came back, and he had worsening back pain, for which the investigations were arranged. So the PSA had gone from 1.8 to 30, and the bone scans showed, again, a multiple metastatic bone disease. And now this man, he's on androgen deprivation treatment. His PSA is rising. He's got metastatic disease more. So that stage is called as castrate resistant, means that he's developing resistance to the androgen deprivation treatment he's on. So now his options are, can I have next slide? Is the treatment options are either the chemotherapy. Chemotherapy is either docetaxel or cabazitaxel. Docetaxel we use in first line. Cabazitaxel we use in when they progress on docetaxel. And his non-chemotherapy options are newer androgen receptor inhibitors like abiraterone, enzalutamide, darolutamide, or apalutamide. These 4 are the game-changing treatment in the prostate cancer. And then you can consider more treatment which are not on PBS, but can be considered in a clinical trial or a compassionate access program like PARP inhibitors or lutetium treatment or radium or clinical trial. So there are a few options which we can consider at this stage, and it depends on various things. Like I will see what's the patient is thinking at this time. Next slide. So John is thinking that what are the side effects of various treatment, and what will give him the best efficacy of the treatment? Is it the chemotherapy, or should he go on a newer androgen receptor inhibitors? What will be the cost involved, because some of the treatment, as I told, is not available on PBS? Does he travel to Sydney or interstate? Are there any other alternate treatment available other than the chemotherapy or the androgen receptor inhibitor? And how will it impact on his family and in his work? So these are his perspective to choosing a second line of treatment. And what is the oncologist is thinking? Next slide. How bad is his cancer? Like, how quickly I need to deliver the treatment to control the cancer? Is he in pain? Do I need to start the treatment urgently in Canberra rather than looking a trial in Sydney? What's the burden of disease? How fit John is? How fit does he able to tolerate the chemotherapy? And can I access any treatment nearby my center? Should I arrange any genetic test? Should I do any PSA test or other things? Next slide. After a shared decision, we started a docetaxel chemotherapy. He was able to complete 10 cycles of chemotherapy. There was no major side effects. So docetaxel was the first chemotherapy that made a survival difference in 2004 and became the cornerstone of treatment. In 2014, ADT plus docetaxel became the standard of care for castrate-sensitive metastatic prostate cancer. I'll show you the graph. Sorry, next slide. This graph, sorry, just a back. So this graph, it showed when we used to do ADT, the survival was around 44 months. And when we used starting ADT plus docetaxel in the patients who presented with stage 4 high volume disease, the survival was around 57.6 months. So there was a great survival benefit. So it became a standard of care to offer chemotherapy upfront for the patients who presented with high volume disease, stage 4 prostate cancer. Next slide. So docetaxel is a quite commonly used in our stage 4 prostate cancer as a first-line treatment. It's well tolerated. It does act on the chemo cells, which are cancer cells, which are highly dividing. It does come with side effects like diarrhea, nausea, vomiting. It causes myelosuppression in terms of the neutrophil cells count going low. We have been using now more a GCSF, which is a colony-stimulating factors with chemotherapy, which makes the neutropenic sepsis rates quite going low. It does cause fatigue and peripheral neuropathy. We use 6 cycles of docetaxel and then just continue on ADT. So that's what John received at that time. Next slide. So he again went from May 2018. His PSA started to rise again, and then whole brain, whole body scan and the CT chest again showed worsening of the bony mets. But he's still well. He's still asymptomatic, and again his options comes with chemo, like the second line cabazitaxel. Now should we use the newer oral anti-androgens, or do we do a clinical trial? Sorry, next slide. So this is the second generation ARP, which I've told that these are the game changers. I won't go into details of how do they act, but I'll just tell you the name, that they are blocking the AR receptors and reducing the testosterone by binding it or by suppressing their synthesis. So apalutamide and darolutamide have come in last 2 years, and abiraterone and enzalutamide has been there for last many years, and they've been using them in a castrate resistant setting. Next slide. So recently there have been approval of 2 RPs, we call them, a darolutamide and apalutamide. So darolutamide is used in more in a castrate sensitive when there's producing in a high volume, and we need triplet therapy, like where there's a liver disease or there's a more nodal disease, then we put them on ADT, we put them on docetaxel, and we put them on darolutamide. And then apalutamide, when there's not such high volume disease, but still they are stage 4 prostate cancer, then we put them on ADT plus apalutamide. And as you can see from this graph, there's a 35% reduction in the death if you put apalutamide and ADT as soon as they're diagnosed. Can you show me the next slide? And there's a graph around the darolutamide and And if you use just a placebo plus ADT plus docetaxel, there's around 42 months of survival. But if you use them all together, then there's around a 6 to 8 months of survival benefit. So when we used to use these medications in the later setting, they have come in the earlier settings now. So that's why early referral to a medical oncologist is now preferred. So if they have got stage 4 disease, we start them on ADT, but we also talk about starting on these new androgen receptor. And sometimes we can avoid doing chemotherapy for many years because they have improved the survival time, they have improved the time to delay the progression, they have improved the time to become castrate resistant as well. Next slide. So because we have been using these drugs more and more, so you will see more and more side effects in the community. So I will specifically go with the apalutamide and darolutamide because these are drugs that are new use we've been using for last 1 year on PBS. And they causes hypertension, so you'll see patients coming with high blood pressure, or they causes fatigue and it causes rash. Other drugs causes electrolyte abnormalities and the other things. And so we really need a combined approach with our general practitioners to manage that toxicity. Next slide. So that's the changing landscape for the prostate cancer that in 2014 it used to be just the androgen deprivation treatment, and now in 2017 it became androgen deprivation treatment plus docetaxel, and now it is either with the androgen receptor inhibitor like apalutamide or darolutamide, or some cases when there's a high volume disease, then we use docetaxel. Leonie, are we running out of time? So if I will just miss the genetics. Maybe I'll just go to the supportive path because that's more interesting. Yeah, so next slide, sorry. So in supportive care, because these are the most important thing for the patients, because they come with skeletal disease, and when we put them on ADT, they're high risk of osteoporotic fractures. So we should really talk about bisphosphonates, and it's usually we use denosumab, and which uses 120 milligram. And sometimes for the early prostate cancer, when we are using ADT, doing a bone density scan is quite important, and the GPs can keep an eye on that. Next slide is another is the exercise, and exercise is the most important thing while they are on ADT. So next slide. And ARCOSA, like Clinical Oncology Society, says that it should be an adjunct therapy, and at least 150 minutes of moderate and intensity of 75 minutes exercise should be recommended. Next slide. And other side effects, I think I've said. I think Greg also. That's all right. We can miss that slide. The other slide. I think it's a combination of the psychological palliative care and the support groups, what Greg alluded, like the prostate cancer support group. We should have a psychologist in our meeting, or we should have a palliative care support to manage their pain and day-to-day. So it's just not one person who is managing the prostate cancer. We should manage it like a team, because medical management is just part, but there are many other parts which needs to be looked at for their optimized care. Yep, I think I got just one more slide. So ADT alone is not a standard of care for metastatic hormone-sensitive prostate cancer. We should intensify their treatment to improve the overall survival. Most patients should have a newer androgen receptor inhibitors, or they should have docetaxel upfront if there's a very high volume disease. And they should all receive germline and somatic testing. And again, I cannot emphasize on enough that it's a multidisciplinary approach with an oncologist, allied health, psychology, primary care physician, support groups to manage the side effects of the treatment. Thank you.
Thank you so much. I'm sorry to rush you through because I think it would be nice to kind of expand on some of the things you were talking about. So if the panel doesn't mind staying on, we've got quite a few questions, and maybe we'll try and, zoom through them. The first question we have is for Patrick, I think. Is the gel inserted in the rectum, or if so, how does it protect the anterior wall of the rectum adjacent to the prostate?
So it's effective. Hodo probably comment on this because he does them, but it's effectively inserted in the potential space between the prostate and the rectum, and then expands that potential space. So it's not into the rectum as such; it's that potential space. And the gel is of a certain substance that it absorbs the radiation like normal tissue. So it's absorbing the radiation that the rectum would ordinarily have been absorbing if it was in that anatomical geometric position. So it's both a physical separation and a dose absorption that protects the rectum.
Might probably show, I don't know whether you can see that there. Here is
fuzzy.
before, this is before and this is after. And it actually looks like a bit of a padding between the prostate and the rectum. So basically that separation, we do it under general anesthetic. We do it with the needle in the perineum. It's similar to doing a biopsy. And we try and achieve a centimeter of separation between the rectal wall and the prostate. And also at the same time, we do the gold seeds, so which act really as a marker for you guys when you do the IMRT.
So this is either for Hodo or Patrick. Is PMSA PET different from conventional PET mainly because of the use of ligand?
Yeah. So traditional PET, positron emission tomography, uses radio-labeled sugar because cancer cells tend to be more metabolically active, so they'll take up sugar more readily, and therefore you'll get hotspots that are signs of hypermetabolism. But a PSMA PET is very specific, so it's using so the radiopharmaceutical is not sugar; it's effectively an antibody to PSMA, which is bound to a gallium-68 source, and that gallium-68 degrades and releases positrons. So that antibody binds to the PSMA receptor or molecule on the prostate cancer cell. So it's fairly specific. There is cross-reactivity with other cancers though, renal, salivary gland certainly, maybe some lung cancers. So you like, for example, if we've got men with early metastatic disease that happens to be in the lung, sometimes we have to do a biopsy to differentiate between lung and prostate. So there's a little bit of overlap there. But generally the distribution of the disease and the uptake will tell you that it's prostate cancer.
I might add something also there, because since we've been using the PSMA PET scan quite a long period in Canberra, we have actually sort of come across to quite a lot of other incidental findings in the lung, which were not PSMA uptake, but there were incidental findings of small nodules. And normally what I do is I send them to a thoracic surgeon for review. Whether then they monitor them, and sometimes they do a biopsy, but we have found them. And also in the thyroid, we have sometimes picked up thyroid nodules, which thyroid cancer. But yeah, it does pick up sometimes other cancers.
Thanks. The next series of 4 questions are all on the PSA. So maybe this one is for Greg and for Neha. So I'll try and wrap them all into one question. So explain the current PSA testing guidelines which have been approved, provide in terms of age and family history. A question about PSA velocity and when do you get concerned about a rise in the PSA velocity? And when do you request a free PSA ratio, or so do you just request a PSA or free in total or ratio? And what are the thoughts, advice to GPs on the changing to MBS funding for PSA testing? So it's kind of all PSA related.
How do you want to comment on PSA velocity? Because
yeah. Well, I think first of all, I think I probably want to say that I want to thank Greg also for mentioning early detection, because I think at the end of the day, I think any cancer, and this is what I tell my patients, any cancer is curable if you find it early enough. Okay, so I think that's very important, and that's a take-home message that we have to send to everyone. I think the key thing with the PSA is that it's got you need to look at the age of the patient, age-specific PSA range. You need to look at, we never would do, for example, a biopsy these days on the one PSA alone. We always look at 2 PSAs. You need to have 2 abnormal PSAs of more than 3 to be able to get an MRI. And as a rule, all patients will have an MRI before having a biopsy of the prostate. So when we talk about PSA testing, we're not really going straight into doing biopsies. These patients are monitored. They have a look at 2 PSAs, do an MRI, and then they would look at having a biopsy. Now, obviously, you need to take it from the history, whether these patients have had any urinary tract infections, because as in Greg's point of view, he had 7 months of antibiotics unnecessarily for such a long period of time to make sure that there's no infection. One thing that I did mention early on was also prostate health index, and in more complex cases, you would want to do probably a prostate health index, and I do that normally by giving patients a couple of weeks of antibiotics with norfloxacin, and then repeating the PSA and looking at the PHI. And it's a very neat test because it does give you the risk stratification for cancer from low, medium, and higher risk group. So I think it is a very useful tool in those patients where the MRI, for example, is equivocal, and rather than doing straight onto a biopsy, you want to try and differentiate those patients that potentially might have inflammation in the prostate and prostatitis. So that's the way that you would look at it. You look at the PSA between less than 4. If they have age-specific PSA of less than 4, you need to tailor it from that perspective. And if it's 4 to 10, the risk of cancer is 30%. And in conjunction with the MRI, then you will obviously discuss the options in terms of whether we do a biopsy or not. So again, so the PSA alone is not now anymore the thing that will get us into doing a biopsy, but it's really raising the flag that potentially there is cancer of the prostate here, and be aware and have a look at it. When we look at the PSA, so this is before you do the diagnosis, and sometimes I have actually used a PET scan in patients that are very adamant not to have a biopsy. I have used a PET scan, which is obviously off-label. I mean, you don't do that as a routine, but I have done a PET scan before doing a biopsy of the prostate to reassure them if there's any significant uptake, then obviously we would proceed to a biopsy. And also sometimes you need to be aware that if the patients have got a pacemaker, you can't do an MRI. Not all institutions can do MRI. Some institutions in Canberra can do it, and we would try and refer to those institutions. But sometimes you need to use a PET scan in that scenario if they can't have an MRI, to try and see whether there's any malignancy there, and then you can do a targeted biopsy according to the PET scan. If you look at the PSA after radical prostatectomy or after radiotherapy treatment, then we're looking at in a different manner. We're looking at the PSA rise, and this is what I alluded then to earlier on, where with Patrick, they've got the new machine there, which has got a much better resolution, and we can probably pick up the spot or the source of the PSA if the PSA is 0.1. And Patrick, you can probably discuss that a bit more, unless you've already touched on that already.
Yeah, I think rise in the PSA, like if there's a PSA doubling time, and if you do an early PSMA PET scan, you can avoid all the androgen depression treatment. Just do a SPRT, as Patrick showed. But I think the question is about the screening because it's the MBS criteria has been changed. Now the patients are charged $70 per PSA blood test. So I
don't think we should look at that as a criteria. Unfortunately, a lot of these things have got we have got barricades that are put in front of us. I don't think a $70 fee should be something that we should take into consideration, and not ordering a test, because potentially that's the life and death of someone in the future. And early detection is the key. You have to explain that. And I think when you need to, clinically, you need to do a PSA. Unfortunately, some of this is not in consultancy with the doctors, because if a specialist is requesting a PSA and they need to make their decisions, I think that should be taken into account. And maybe that's where Greg can use his influence in parliamentary sort of address when he does that, and try and say, look, maybe it should not be used, ad hoc, but if it's requested by a specialist, that should be taken into consideration. But I don't think we should make our criteria just on a $7 fee.
Yeah, I think early detection is the key, because you are saving so much side effects. And from
how much would it cost for abiraterone and darolutamide?
Supply.
Sorry?
It's
Yeah.
a $7,000 a month supply. So
Exactly. I mean,
exactly. So those
$70
costs
for
are
a
much, much
PSA and a
higher.
$7,000 a
Exactly.
month supply. It doesn't make sense, does it?
No. So yeah, I'm totally agree with you, Hodo, that we should be doing early detections and doing PSAs more.
And this is something that we are working, and PCFA is working closely with the federal government. I mean, one of the things that we are very fortunate about with our parliament, where they rarely all agree on one thing, is that we do have bipartisan support for men's health. What we need to do is we need to keep putting the pressure on the Minister for Health, that we can come up with this opportunity that where men can have this PSA test. But I guess, I think that I totally agree with Dr. Haxhimolla, and I think him and I've chatted about this previously, is that I think as a clinician, as a GP, my suggestion is that, you don't make price the issue, because, when you look at people's lifestyles, their cars, all that sort of thing, $70 for something that can effectively greatly improve your health outcome is a minimal price to pay. I mean, in today's standards, it's a couple of decent bottles of wine. It's a carton of beer, if you want to put it at basic levels for blokes. So yeah, please don't GPs that out there, do not let that be an issue for you. I think you just need to. It's about the benefit of the early detection, and the fact that if they can avoid metastasized prostate cancer, then their outcomes, their lives are just going to be greatly improved.
And that was the main thing of me putting that statement done by Royal Australian College of Guidelines, that they're still saying there's no obligation, which I think should be changed. Yeah.
And hopefully through the guideline changes that will occur. And I don't want to get sort of too in depth on this at this point in time, because I've been part of that committee, and I think it's due for release in August or September this year. But essentially, when those guidelines come out, and more importantly, hopefully, Leonie, is that these set of guidelines actually do reach the GP's Red Book, because my understanding is that the current guidelines are actually not reflected in the Red Book as it stands.
That's correct. Yeah. So the current guidelines in the Red Book are from 2013, but interestingly, Health Pathways has the more up-to-date recommendations. So possibly people should kind of review their local health pathways rather than the Red Book in this situation. I apologize.
Website, Leonie, is a great resource. They keep those guidelines up to date as well.
Yep. Apologies, there are a couple more questions, but I think we'd better wrap it up. There is one comment in the chat about pre-op care is one area that could really be improved, particularly with Cialis and with penile health and pelvic floor retention post-op. So that's good to note. Probably we don't have time to go into that and to do it justice. So I just thought maybe we'll just wrap it up now. And I would like to thank everyone so much for their passionate and in-depth presentations. We really appreciate the time and effort you put into your presentations. And as you can see, there's a lot of interest in the topic. So people can contact the ACT Prostate Cancer Support Group for more information. And this presentation itself will be put on our Capital Health Network YouTube page, so it's also there for review. Please fill in the post-event evaluation survey, and we'll send you out the certificate of attendance and to record 1.5 hours of CPD educational activity. Thank you all very much, and good night.
Thank you. Thanks.
Thanks, everyone.
Thank you.
Thanks.
Bye-bye.